Thank you so much, and welcome to everybody. I hope you can hear me okay. Please shout up if you can't. Um, so yeah, it's almost bedtime here, so I shall get through the talk and leave you to it for the rest of your afternoon. I decided to talk to you about Mycoplasma genitalium. There was a few things that I was considering, but I think this is something that really isn't discussed a lot in South Africa. At least it wasn't when I was working there. And without tests in the public sector, it's quite difficult to really know what's going on in many countries, South Africa included. I'm not quite sure, and you'll be able to let me know what's going on in the private side of things later on when we get to the questions and discussion. So I've entitled it Troublesome Bacteria for the 21st Century. It is very troublesome and it's difficult to manage for many clinicians. So just by way of background, it's a very, very small bacterium. It's got a tiny genome, just 580 kilobases, and it attaches to cells through the tip of this flask-like appearance of the bacterial cell. So right on the tip there, there's the concentration of the Mycoplasma genitalium surface adhesins, which are very like the ones in Mycoplasma pneumoniae, and that's what gets it stuck onto cells. It can grow extracellularly and intracellularly, but it's extremely difficult to culture in vitro. Only a few labs in the world can do it, and it takes many months to get the organism to grow. So there's no way it can be used for diagnostics. So we've had to rely on molecular diagnostics, which, as they've come forward, have enhanced our understanding to some extent of this pathogen's role, but there are still many unanswered questions, some of which I'll allude to as I go through the clinical part of the talk. And we also have assays, which I'll discuss at the end, which can simultaneously now detect the organism as well as susceptibility to macrolides. So what do we know about the background prevalence? Well, there have been three big studies, but they're all quite old, and one in the US, one in the UK, and one in Denmark, looking at young men and women on the whole. Fairly large numbers, as you can see, almost 3,000 in the US study, 4,500 in the UK study, and about 1,600 in the Denmark study. And the prevalence in men and women is pretty much the same, about 1.1% in men, 1.2 in the second study, 1.1 again in the first study. For women, a little bit of variation from 0.8% in the first study in the US up to 2.3% in the study in Denmark. There were some associations you wouldn't be surprised to see, given that it is an STI, that there's a strong association with increased numbers of sex partners. And as with many STIs in these countries, due to predominantly to social deprivation and inequalities in the levels of education, STIs tend to be much more common amongst people from Black races, as described in the papers. Now, if you want to look at men who have sex with men, that we mainly see in our clinics here in Australia, there's a couple of studies here which I'm just showing you from Melbourne and one from my own clinic. The Melbourne study basically looked at six sex on premises venues where they recruited people going to the venue, obviously, to meet people. And most of them would have been asymptomatic. For us, at our study, we were seeing consecutive men who have sex with men coming in, some with symptoms, some without. So there's a mix there. But what you can see overall in the sex on premises venues where you've predominantly got asymptomatic people, because they're not a clinic population, M genitalium sitting around 2.1%. But for us, in a clinic setting with people presenting quite often with symptoms or else for PrEP services and therefore maybe being asymptomatic but at higher risk, about 13.4% overall. It was interesting to see that in both venues, both cities, the throat, there was no M. genitalium detected in the throat at all. So that's very different to gonorrhea and chlamydia. And the highest rates tended to be, are often seen in the anus. Though for us, we saw quite a lot of urethral infections, again, because people were symptomatic coming into the clinic. It's important to realize that if you look at men who have sex with men who have non-gonococcal urethritis, it's more often than not that you don't find a cause and so-called idiopathic causes compared to heterosexuals where you're more likely to pick up chlamydia trachomatis or M. genitalium. And there certainly have been reports in the past that M. genitalium is more prevalent in men who are living with HIV, but it's not always the case. And I wanted to show you one study that we did here. Actually, it was in Cape Town, down at Salt River, back in about 2007, and in Johannesburg, up at Alexandra Health Centre. And we looked at a number of things in that paper, but one of them was to look at the association between HIV serostatus and the other infections. And the only infection that was highly significantly linked to living with HIV was having HSV2 seropositivity when we looked for antibodies in the serum. But there was no association with M. genitalium or any of the other bacterial or protozoal STIs listed there. So what's the evidence to support sexual transmission? Well, there's high concordance of M. genitalium infections between sexual partners. And also when people have looked at multilocus genotypes, there have been identical genotypes reported among about 87% of co-infected partners. There's increased prevalence in the high-risk groups for STIs, as I've already mentioned, and associated with larger numbers of sex partners. Now, we don't really know the transmission efficiency, but we do know for chlamydia it ranges between about 10 and 40%. It's thought to be likely to be a bit lower for M. genitalium because the bacterial load is generally lower as well. And it's thought that symptomatic cases where you tend to have a higher bacterial load are likely to be more infectious. So probably in the region of 5 to 10%. So looking at M. genitalium in men, it was basically first isolated from urethral samples of 2 men with non-gonococcal urethritis, and they've consistently been, in numerous studies, strong and consistent associations with NGU. As I mentioned, higher bacterial loads in symptomatics, and it's therefore not surprising to hear that pro-inflammatory cytokines are released during infection, which makes all of that biologically very plausible. M. genitalium obviously a bit more common in men with symptomatic NGU compared to those without disease. As you can see in those that review by David Taylor Robinson and Jürgen Jensen. Some of this data is a little bit old now, but it's still quite, I think, fairly reliable. Hasn't changed that much. The table is quite useful, and it was put together in that review because it basically looks at the chlamydia trachomatis criteria and the M. genitalium criteria, and you can actually see it's pretty much the same. So, there was always a lot of trouble proving at the beginning that chlamydia was sexually transmitted. You have to go through all these sort of things to look at controls versus acute cases, chronic cases, any data from animal work, human volunteers, and so forth. So, basically looking at this table, you can really see that it's very similar to chlamydia. Now, back in South Africa, again, we did a number of surveys over the years I was there. And this is just showing you the relative prevalence, right, amongst men coming in with urethral discharge syndrome. So they'd all have a urethral discharge. And by and far, the most common cause was gonorrhea in the red, followed by chlamydia in the orange. We did see some trichomonas, not surprisingly, often co-infections with one of the other two, and that's in the yellow, and the green is the M. genitalium. So Mycoplasma genitalium is the main organism associated with persistent NGU following first-line treatment. Going back to that study looking at Salt River Clinic and Alexandra Health Centre in Joburg, you can see here that we saw quite a higher prevalence of M. genitalium in our male urethral discharge patients in Joburg compared to Cape Town. So there were some interesting differences, whereas there was a lot more gonorrhea, as you're probably well aware, here in the Salt River area, at least at that point in time. So international guidelines, where you've got testing available, does recommend M. genitalium testing for men presented with non-gonococcal urethritis. But I think it's important to talk a little bit about what happens if men present with gonococcal urethritis, and that may be a clinical diagnosis based on, huge amount of purulent pus coming out, very typical appearance of gonorrhea. People say, should we treat for M. genitalium as well at the same time? This is often a problem when you've got syndromic management. How many bacteria do you cover? So the guidance is not out there for that. But what we do know from the studies that we did in South Africa, and we had very similar findings here in my clinic in Australia, was that if you look at the co-infections, actually the rates are pretty low. They're well less than 10%. And a lot of them, well, where we are in Australia anyway, we still use azithromycin and ceftriaxone to treat our gonorrhea patients. And so that azithromycin is managing to get rid of most of the M. genitalium that is there as a co-infection. So we just get one or two cases in the study that we looked at where we had to retreat them with moxifloxacin. So it's not a big problem. And I think it's generally advised, best thing is not to go blunderbuss therapies at the beginning, but rather to focus your treatment on the common causes, which are gonorrhea and chlamydia. Then you need to wait and see if they get better or not. Now, the flow charts, when I was there, they used to say, well, give a trial of metronidazole for trichomonas. That was all that was in there. And if that fell apart and nothing happened to the patient, they were still symptomatic, you used to refer to a specialist. I guess in Cape Town, there would be you in infectious diseases because there is no sexual health specialty in South Africa. So it's always a problem knowing who are the specialists and how much experience people actually have of managing these sort of complicated end-of-the-road conditions where things aren't getting better. But that being said, some of these patients will appear somewhere in the hospital system. When I was in Brazil in June, I was asked to talk a little bit about this whole topic of what to do in the context of urethral gonorrhea. And it became very apparent there that in Brazil, they've started using multiplex tests coming from some of the companies from, Korea and so forth, which have got 7, 8 different targets. And then doctors are getting all these results. And then having the positive result from genitalium, they feel very uncomfortable not to do anything about it. So it's actually driving a lot of treatment for something that perhaps might not be so necessary. So I think there's something to be said for going for the dual gonorrhea chlamydia test first, so you don't get yourself caught up with having a positive result you've got to manage. Then if you do a test, and we'll talk about this later, it's very important, if you can, to access the tests which give you some sort of guidance on which antibiotics to use. So this is a big stewardship issue. And in my view, the multiplex tests, they can have a role to play, but it's really in the cases which are not responding to the standard therapies, and you are looking for something a little bit more unusual. So I mentioned about the M. genitalium being successfully covered with dual therapy that we use. I'm not quite sure what the case in South Africa now. There have been a few changes to the guidelines since I left, but also some clinics will also give azithromycin as a chlamydial cover. But there's been a move away from azithromycin because of worries about antibody resistance and the long half-life of the drugs, over to using more doxycycline. But doxycycline really doesn't work very well for M. genitalium. It can reduce the bacterial burden and the load, but it generally won't get rid of the infection. What's really important is to focus treatment on patients who have persistent symptoms, and really important is to avoid doing test of cures. We've stopped doing test of cures completely now. If the patient's still symptomatic, we might repeat testing to see if they've got further resistance, because we're seeing, certainly in Australia, a lot of resistance to quinolones, fluoroquinolones, as well as to macrolides. So we do repeat testing if they're still symptomatic. But if the symptoms have gone, we just encourage people and tell them not to do a test of cure. It's very hard for the patients because we're often doing test of cures for gonorrhea, so they don't quite understand why we have one approach for one infection and one for another. We also don't treat casual contacts. So unless it's a regular partner and we're in a regular relationship, we will tell them, don't worry about it. We'll just treat you based on your symptoms, but we're not going to offer treatment to your partners, and we wouldn't start any contact tracing. Okay, so that's about urethritis, which there's no doubt it's an important cause. So what about other syndromes for men? So proctitis, there is a little bit of evidence, but very little out there. So there's a study from Melbourne that showed a 12% M. genitalium prevalence amongst 154 men who had sex with men with proctitis. That compares to 25% gonorrhea cases and 19% chlamydia and 18% herpes. So not the major cause. They did again show bacterial load was higher for M. genitalium in those men who had proctitis versus asymptomatic men. And also, we don't at this point have any treatment effectiveness studies for proctitis for M. genitalium. So we're lacking some important clinical supporting data. In terms of epididymolysis, some people claim that it may be a cause of acute epididymitis in some patients. However, it's still not proven. In my experience, they generally all get better on prolonged courses of doxycycline, and it's usually chlamydial in origin. But of course, you've got UTI organisms to think about, as well as Neisseria gonorrhea. But there was one study from Japan which reported M. genitalium in 8% of just 56 cases of epididymitis in men that were under 40, and that compared to 50% of the cases where chlamydia was found. The big issue is, just because you find it, is it actually causing any trouble? And that question, again, has yet to be answered fully. In terms of prostatitis, again, a real mixed bag of results. So I was able to find four studies which kind of conflict. So the first one showed basically no M. genitalium detected by PCI and prostatic biopsies from 50 people with chronic abacterial prostatitis. Another study showed just 4%. Another study looked at semen and found M. genitalium in 2 out of 18 men, compared to 0 out of 20 controls, but that wasn't significant. And the only study that's really shown any strong positivity, which is an interesting study, came from China by Mo et al. There were 235 Chinese men with prostatitis and 152 asymptomatic STI clinic controls who they managed to persuade to have prostate massage, given they had no symptoms at all. That was quite an interesting study. I'm surprised so many people actually agreed to have that procedure done, because it's not a particularly pleasant one. The PCR assay for M. genitalium was positive in 10% of those with the clinical prostatitis and 3% of controls. And that was statistically significant because they had quite large numbers. And there's been one study which reported balanoposthitis, but no one else has talked about it. And obviously further studies are required, and it's probably nothing to write home about. So I'll say a little bit about women, because women, it's a little bit more important because of the implications for pelvic inflammatory disease. So the most important thing to stress is that M. genitalium is not thought to cause vaginal discharge. So having a vaginal discharge should not be an indication to take a test for M. genitalium or to treat for M. genitalium. And as you know, that's the commonest syndrome that presents to primary healthcare clinics in South Africa and many other countries around the world. but there's no association with vaginal discharge. And then if you look at female urethritis, most of those studies have only been conducted in Scandinavia. We have a lot of data missing from other parts of the world. Harold Moy and colleagues reported a significant association with microscopic urethritis in one large study, but 3 other Scandinavian studies failed to show any significant association. So this is the problem. You've just got a handful of studies and they don't agree with each other. And there's also an issue about having to exclude patients with concomitant cervicitis as inflammation at other sites near to the urethra, like the cervix, may cause urethral contamination and a false positive diagnosis of urethritis. What is important is mucopurulent cervicitis. So this is, again, a difficult one to diagnose because clinically there's no standard diagnostic set of criteria, but it can be characterized by clinical signs such as a mucopurulent discharge visible on speculum examination, friability at the cervical os, or by elevated neutrophils and endocervical smears, i.e. microscopical testing. The M. genitalium has been positively associated with the microscopically proven cervicitis, but only in some of the studies with a cervical discharge. So there's a little bit of difference there. If you're a real purist in the STI world, you prefer to define your urethritis and cervicitis with microscopy, but most places don't have microscopes to do that work. So in practice, most people are diagnosing cervicitis by clinical appearance on examination. You do need to control for other causes of cervicitis, like especially chlamydia infection. And when you control for that, you still find significant associations between cervicitis and M. genitalium. But there aren't any studies controlling for the effect of gonorrhea. So that's still a gap, and that needs to be tightened up a little bit in further studies. And the magnitude of the increased risk of cervicitis is comparable to chlamydia and gonorrhea. And then moving on from cervicitis, as you move further up, the genital tract pelvic inflammatory disease was actually linked a long time ago, in 1984, through serology with M. genitalium infection, and later detected by NATs in both fallopian tube samples and endometrial samples from women with acute PID. And there have been several studies to show positive associations between M. genitalium and clinically diagnosed in PID in multiple populations in different geographical areas. It's also been associated with endometritis in a small number of studies where the actual endometrial biopsies were taken. And one of the problems has been studies have been hampered by the suboptimal specificity of some of the clinical signs used to diagnose PID. And as you will appreciate, the only way you can really diagnose PID is through laparoscopy. The clinical diagnosis is notoriously insensitive and sometimes low specificity as well. Okay, let's move on to the next one. So pregnancy complications and infertility. So M. genitalium has been associated with preterm birth in some studies, but not all, and in a recent meta-analysis, which I'll share with you shortly. Consistent strong correlations are reported between serological evidence of M. genitalium infection and also laparoscopically confirmed tubal infertility. There was another study which showed NAT detection of M. genitalium endocervical samples, and it was more frequent in infertile women compared to healthy fertile women. But other studies have indicated that endocervical testing is not actually helpful in predicting what's going on in the upper genital tract. There has been some work in experimental models, so subhuman primates, mice, fallopian tube organ cultures, and they have indicated M. genitalium can colonize the upper genital tract, leading to salpingitis and/or endometritis. So here we've got some pictures to show you what happens with fallopian tube in vitro organ cultures. So you can see the cilia and the cells there in the superficial lining with the nuclei, all in sort of orange and black. And then you've got the M genitalium with the fluorescent green protein in it that's shining up green, where it's all stuck on the top of the cilia. And then if you have a look down below, on the left-hand side, you can see an uninfected control with nice cilia wafting away in the breeze, all looking very healthy. And then the one in the middle shows what happens when M genitalium is present. You start to get these cilia swellings, and eventually it gets to the point where nearly all the cilia are killed off. And then you can see on the slide on the photo on the right, you'll be able to see there hardly any cilia left, lots of swellings. And also where those arrows are pointing, that's actually M. genitalium bacteria stuck onto secretory cells on the fallopian tubes. So I did mention there'd been a systematic review. So this slide, just one slide to quickly summarize it. It was published in 2018, and it's a very good read if you're interested in this topic. So they looked at the associations between M. genitalium, these 5 reproductive tract syndromes, which I've already gone through. Very well designed study, 1,080 relevant studies, performed very well. They had a good look at study heterogeneity and publication bias using funnel plots and Begenecker tests. And they also did a lot of rating of the methodology. Overall, what they saw was approximately 2-fold increased risk for all 5 conditions if M. genitalium was present. And all the pooled estimates from the various studies were significant, except for infertility, where there were less studies, and that wasn't significant, but still had the 2-fold risk, but with wide confidence intervals. Okay, so I'm going to move on a little bit now to antimicrobial resistance. So I'm sorry it's a bit of a busy slide. This is just published about a month or so ago. It's an update on a previous paper that was published up until data for 2017. So what they've done on this paper is just add an extra plot for an extra point for the 2018 to 2021 data point. Panel A at the top, or at least the graphs on the top row, that's macrolide resistance. The second row, B, is fluoroquinolone resistance, and panel C is where you've got fluoroquinolone and macrolide resistance. And they based the prevalence on the 23S ribosomal RNA gene polymorphisms that are known to cause macrolide resistance, typically at 2058, 2059 E. coli numbering, and then also the PAR-C, which is typically the serine 83 mutation, and for the fluoroquinolone resistance. And what they saw in 2018 to 2021, for that 3-year period, macrolide resistance overall was 33% across the world where it had been published, 13.3% for fluoroquinolone resistance, and dual class resistance 6.5. Now, this data came from 166 studies. Nearly all of them reported macrolide resistance. That was 157 of them from 41 countries. But there was also 89 reporting fluoroquinolone resistance. So that involves having to sequence, and that's not done so frequently. And then for the dual class resistance, it was 74. Usually, if you're doing fluoroquinolone resistance testing, you can do the macrolide resistance testing as well through some of the assays that I'll show you. So what you can see overall, I think for me, the most alarming is if you look at the third row, C, what you're seeing in Western Pacific region is a continual increase. Although it's not a significant change between the penultimate and the current period of surveillance, overall the trend is highly significant at 0.005, and it is definitely getting worse, and it's starting to happen in Europe as well. Europe is probably more important for South Africa because obviously, as you know, a lot of people go backwards and forwards to Europe for holidays, less so come over this way. African region, as usual, very little data. There's just one or two papers. I think a couple from the NICD. There might be one or two others from Pretoria, but very little has been published in the African setting. So it's again, we don't really know what's going on. We hope it's less severe than countries which have used more antibiotics and a lot more azithromycin over a longer period of time, such as Australia and Japan. You can see as well that if you look overall, that's the global ones, you can see that things seem to look like they might be settling, but there might even be a drop in macrolide resistance. Certainly, there's a suggestion that that's happening in the Western Pacific, but that's not significant. And also in the Americas, but again, not significant. And yet there's been increasing going on in the European region. So changes are happening around the place. But there was a big move, like in Australia and New Zealand, for us all to get rid of azithromycin a good few years ago from treatment for chlamydia, and that may be starting to have some impact now. So potentially that could be one of the explanations. Surveillance for M. genitalium antimicrobial resistance is done really nowhere except the UK, as far as I can see, and they've done 3 surveys. They're trying to get it up and running now in Australia, and there's a paper that's currently about to go off to a journal to look at that. So we might have some Australian data shortly. US could probably do some work as well, get some of this data out. But it is difficult collecting that data because M. genitalium is not a notifiable disease either, so the labs don't notify results to public health departments. But in the UK in 2023, the last of the 3 surveys, there were 928 specimens with linked demographic and clinical data. In the macrolide resistance was 62%, fluoroquinolones 12%, and 10% for the dual resistance. And at the time in the UK, basically the treatment was a 3-day course, 1 gram of azithromycin on day 1, then days 2 and 3, 500 milligrams. Australia and many other parts of the world, we give a 4th day of 500 milligrams to make it 2.5 grams in total. But they only report, the reports suggested that they're only using those 3 days in the UK. Or some people also got treated with second-line moxifloxacin if it was required. And basically they saw a high success rate for those that were macrolide susceptible, 95.4%, and then high treatment success, 98.3% if you use moxifloxacin when you had a fluoroquinolone susceptible infection. They also use a lot of doxycycline, as is recommended now as the pre-treatment. And I'll go through that when I get to the treatment slide. That's for a week before you start the azithromycin or the fluoroquinolone. This just shows you the 3 years of data, 2019, 2020, and 2023. So a slight suggestion that macrolides prevalence of resistance is dropping, but not significant, as I recall. As you can see, the dual infections have definitely increased from 2019 to the last 2 surveys. And it looks like there's a trend which one would expect to see in the fluoroquinolone resistance as we're using more of it now. And I've pointed out earlier that where the mutations are in the E. coli base numbering 2058, 2059 in the 23S ribosomal RNA gene, region 5, and then the PAR-C is the important one for the fluoroquinolone resistance, mainly at the serine 83 site, but also D87 is another important target. If you get JARA mutations on their own, they're not associated with resistance, but if it's combined with existing PAR-C mutations, they're twice as likely to fail moxifloxacin as if it's PAR-C mutations alone. Okay, so let's get on to the treatment. So this is how we treat in Australia. We have the assay that allows us to determine macrolide susceptibility, which I'll go through after this. So just understand that. So we get a report that says macrolide susceptible, macrolide resistant, and then we treat accordingly. So the first thing we do is, we usually when we see the patient, they've got a urethral discharge. While we're waiting for this macrolide genitalium test to be done, we put them on doxycycline for normal standard treatment of non-gonococcal urethritis and cover for chlamydia. They take that for a week. They'll come back. We'll have the result back by then. And then, if it's susceptible, we give them the 1 gram stat azithro, followed by 3 days of 500 milligrams, a total of 2.5. And then we'll tell them, come back and see us if you're not better. Otherwise, don't worry, go home and leave it. But it's important if you do end up, you have to understand that there's a very slow growing organism. So often they'll get better straight after the treatment. And it may not be till 3 or 4 weeks later they start to get symptoms return. So it's very common. So when we used to do testicles more regularly, we used to bring them back at 4 weeks. The longer you leave it before retesting, the better. But as I said, we've just got so much problem now managing some of these cases. If they're multi-resistant organisms and they've got no symptoms, there's very little we can do for these patients except turn them into psychological wrecks, which is not the name of the game. So we try now not to do test of cures unless they're still symptomatic. Then if they're resistant on that test, we'll go straight after the doxycycline to give them oxyfloxacin for 7 days, 400 milligrams a day. Some people give 10 days. The general feeling, and Jürgen Jensen, who's the world expert on M. genitalium, the feeling is that his view is now that you need to treat longer than probably that we have been doing, just because of the slow growth of this organism. So I personally always give 10 days, and usually the moxifloxacin will work. It's rare that I have to give something else, but certainly have had cases where that's happened. If they fail the moxifloxacin and they're coming back and they've still got discharge, and we test them again, it's still present, then the options that we've had up until now have been pristinamycin, which is quite expensive, and as you know, it's often kept for staphylococcal infections and hospital related issues, not a drug that you really want to be using a lot in the community. Citalfloxacin, which we used to import from Japan, the pristinamycin came from France, and minocycline, which is a very old drug, but it seems to have better MICs than doxycycline. So there have been some success. A few cases, maybe 60% of these highly resistant strains have been cured with that in a small handful of cases that anecdotally we've looked after. But the pristinamycin now we can no longer get it from France, and citalfloxacin is no longer being exported from Japan. So we're just left with minocycline at this point. As I said, about 60% of the times it'll work, and then we end up with 40% we've got nothing to give them. And so we're getting this, gradually building up this set of people who are totally obsessed with their M. genitalium infections, terrified they've got untreatable STIs. It creates huge morbidity for them, and psychiatric or psychological harm. So you've really got to think about what we're actually doing, and it's about treating the patient, not necessarily treating the lab report. And ideally, symptoms need to be very much in the middle of all of that. There are some other drugs where there's potential activity, but none of these are actually used. So there's lefimulin. Soliframycin was used in a trial for gonorrhea. It does have activity, quite good activity against M. genitalium, but it's not being pursued. And there's 2 new drugs come out now from phase 3 for gonorrhea treatment, gepotidacin and zoliflodacin, both of which have M. genitalium activity. So whether there'll be a place for them in managing some of these very hard to treat salvage therapy type cases, it remains to be seen. But we really are running out of antibiotics, and I think that we're going to end up with probably this will be the first incurable STI at some point in the next decade or so. So in terms of diagnosis, I said I would say a little bit before I finish. So we can't do gram stains. Cultures, I told you, a couple of labs can do it, but it's no good for diagnostics. It takes months and months. Serological testing, there are tests, there are serological assays used for epidemiological studies, but there's nothing for a diagnostic test. So we're very much based on nucleic acid amplification testing, and so therefore that excludes most of the countries in the world where the health budget doesn't allow those sort of tests to be run as a routine. These are just some of the examples of the tests that are out there on the market. So, there are single PCRs for M. genitalium, as you can see there, or you can have a panel. This one's for TMA, so from abdomen. So that was got chlamydia and Neisseria gonorrhea, which, sorry, that came from the website. It was spelled incorrectly. I can't change it. Trichomonas vaginalis and Mycoplasma genitalium. So, that's not a bad panel because all those are important infections if you're looking at urethritis or potentially cervicitis as well. But there's also a lot of in-house assays, and they have variable quality, and validation is not always great. But many labs still do in-house. And then I told you about some of these kits. So here's one, for example, the C-gene. It's called Allplex STI Essential Assay, STI 5. But it detects up to 7 pathogens. This one's the box for the 5, but there is a 7 pack, which a lot of people are using now, and they're being pushed by a lot of diagnostic companies. Detects chlamydia, gonorrhea, M. genitalium, trichomonas. That's all great. Mycoplasma hominis, it's not really relevant unless you're pregnant. There isn't any real issue with the Mycoplasma hominis. And when you get positive results, we've constantly been phoned up by GPs. What do we do with this result? And we had time to ignore it. So it's very frustrating. Ureaplasma parvum doesn't cause any STIs. And Ureaplasma ureticum, if you're in France and a French physician, you'll believe very strongly it's important in NGU. If you're from the UK, traditionally, we never felt it was important. But I think as time's moved forward and molecular assays have managed to split Ureaplasma ureticum into these 2 species, parvum and urelicum, it turns out some of the original ureticum was actually parvum. And so that's why there's inconsistent studies. So Ureaplasma ureticum definitely now seems to be linked to NGU, but it's not a very important cause. And then I came across this My Lab Safe is Sexy on the website today, and this is from Oman. And what they do is you can buy it, and it's basically a self-collection kit, which you can use at home, take a swab, send it off to the lab, and they'll test for M. genitalium. They'll do all the different STIs for you, but you can order your own M. genitalium test and just get it done at home, which for me is just like so frightening now that we're actually doing home-based screening for people with a condition like this, is which we're struggling to manage. So what do? We use this resistance plus MG. I don't know if you have it in South Africa or not, but it's really a very good assay. It was a standard kit, as you can see from the top picture, but now it's been linked in with the Gene Expert system. There's been a lot of work with Kefid to get the technology into their cartridges, and it's called a flexible cartridge. And it detects M. genitalium and also detects macrolide resistance mutations in the 23S ribosomal RNA gene, specifically 4 different mutations, 3 at 2058 and 1 at 2059. And they're able to do this with this very interesting Plex PCR real-time PCR technology, which uses Plexzyme enzymes, which can detect and report the amplified product through generation, basically, of a fluorescent signal. I mean, that's how it's all how the testing is actually worked, and how you get the signal through the breaking of the quencher and the fluorescent label. So yeah, this is great technology. It's really helped us, and visit to hear whether you have access to it or not in South Africa. This was a evaluation that was done in Melbourne of the original kit. So that's the one at the top here, SpeedX one. Looking at 1,089 consecutive anogenital swabs in either asymptomatic or symptomatic males or females. Overall 6% positive for M. genitalium and 63% had macrolide resistance mutations. And you see the performance is very good. So for detecting the organism itself, the sensitivity 98.5%, specificity 100%, positive predictive value 100%, which is really important for clinicians. Negative predictive value 99.9. And then looking for the mutations, the presence of the mutations, sensitivity 100%. So if it's there, it really is there. But the specificity was a little bit low, 96.2. So sometimes you'll get a report that the mutation isn't present, i.e. it's susceptible, but actually the mutation might be there. So that can happen. So if a patient doesn't get better on azithromycin, you just have to bear that in mind, that it might actually have resistant mutation that just didn't get picked up. The positive predictive value is a little bit lower, 97.4 for the mutation detection, but the negative predictive value is very good at 100%. So just to conclude, M. genitalium is an STI that you can see presents a lot of clinical challenges. Its causal role in NG is obviously clearly established, and there's clear links now with cervicitis, endometritis, PID, spontaneous abortion, and preterm labor, potentially as well with infertility, although it was non-significant in that meta-analysis. Regarding other male syndromes like proctitis, prostatitis, etc., the role remains very unclear. Treatment is, as you can see, is becoming increasingly difficult as AMR increases, particularly the fluoroquinolone resistance and the dual resistance cases, and also lack of access to drugs like pristinamycin and citalfloxacin now that we used to have access to before. I think I really wanted to make the point, I hope I have, that any diagnostic testing done should be limited to investigation of appropriate clinical presentation. So definitely not vaginal discharge, and avoid screening people who have no symptoms at all, because you end up generating, we had one sex worker who had no symptoms whatsoever, but the nurse thought it would be good to do it because she was a sex worker. And then she was found to have M. genitalium, which failed azithromycin, the moxifloxacin, pristinamycin. She failed citalfloxacin. Eventually, we managed to get her cured with the minocycline. She was the first one that I looked after that I used minocycline in. But she was in therapy at the end of all of that, and she couldn't go back to work, and there was all sorts of issues for her. But the thought of having an incurable STI, and she'd actually got sexually assaulted. That was the other reason the nurse did it, because that was just made her feel even worse, that the sexual assault had given her this incurable STI. So you really got to think about the psychological impact of what we're doing at all times. And with that, I'll finish. I hope that was interesting, and happy to answer any questions and also hear a little bit what you're doing down there in Cape Town.
Thank you very much, David.